Great. Well, welcome everyone to this session of the AI Nurses Network. For today's webinar, we have a wonderful nursing researcher, Dr. Brigitte Woo, who's based in Singapore. She's a Senior Harkness Fellow in Healthcare Policy and Practice and a visiting scholar at the University of Pennsylvania School of Nursing. And today she's going to talk about large language models in nursing. So over to you, Brigitte.
Thank you so much, Dr. Siobhán, and I'm so happy to have the opportunity to share my presentation, on large language models in optimizing nursing documentation. So maybe let me start by giving an overview of today's session. So first, I will introduce the use of large language models or LLMs in clinical documentation tasks. We'll look at how these tools can support clinicians by reducing time spent on paperwork, improving accuracy, and potentially enhancing patient care. Next, I'll share some findings from studies I conducted at Penn Medicine Health System in Pennsylvania, USA. And these provide some real-world insights into how LLMs are being tested and evaluated in a large, complex health system. Finally, I'll discuss the broader implications of AI and LLM implementation for health systems. This will include both the opportunities and the challenges, such as integration with EHRs, workflow redesign, workforce training, and issues around trust and governance. So in short, we'll move from the introduction of technology to evidence from practice, and then to a discussion of what this means for health systems moving forward. So before diving into the applications, it's helpful to situate large language models within the broader field of artificial intelligence. So at the outer level, we have artificial intelligence, or AI in short, which refers to computer systems designed to perform tasks that typically require human intelligence, such as reasoning, learning, or problem solving. Within AI is machine learning, which uses algorithms that learns patterns from data rather than relying on explicit programming. A subset of this is generative AI, and these are systems that don't just classify or predict, but actually create new content, such as text, images, or even audio, based on the data that they have been trained on. And within generative AI, we have large language models, and these are advanced models trained on vast amounts of text data, allowing them to generate human-like language, summarize information, answer questions, and even support clinical documentation tasks. So LLMs are not separate from AI. They are one specific branch within this hierarchy, but a branch that has gained particular importance in healthcare and clinical contexts. This slide shows how LLMs actually work and why they are increasingly being tested in healthcare settings. So on the left, you would see the types of data that LLMs can be trained on, such as text, voice, structured data, images, even complex signals. And through a process of training on very large data sets, the model learns how to recognize patterns in language. Then, through adaptation, it can be fine-tuned for specific contexts, such as in healthcare. On the right, you can see a range of tasks an LLM can perform, things like information extraction, pulling out important details from long notes or instruction following, where it can generate a specific type of summary if you ask for it. It can also support Q&A, question and answering, which means responding to queries about patient records or sentiment analysis, which could help in identifying concerns or risks in free text notes. So when you understand this process, it becomes clearer why LLMs are increasingly being harnessed to support clinical documentation tasks. For nursing specifically, this could mean automatically drafting progress notes, generating handover summaries, or even pre-filling discharge documentation, saving nurses time and reducing duplication. After understanding how large language models work, you might be wondering why I chose to focus my fellowship year on this topic. So, as a nurse, I've seen firsthand how much time is consumed by documentation. Many of us spend hours in front of the computer, often late into our shifts, documenting care instead of being at the bedside. And we know this work is important, but we also know it doesn't always capture the reality of what nurses actually do. And, that kind of tension kind of stuck with me for some time. So, when I had the opportunity to come to the US on the Harkness Fellowship in Healthcare Practice and Policy, I've decided to dedicate my year in examining whether LLMs could support nursing documentation. And my goal is to explore not just the technical feasibility, but also the human side of things. Like, what does this mean? What does this mean for nurses, for patients, and for the health system? So to guide this work, I framed a few key questions. So what do nurses themselves think about the use of LLMs in documentation? What challenges are they facing today with the way we document care? How well does current documentation reflect the real and often invisible work of nursing? And ultimately, how can we use LLMs to thoughtfully support nurses in documenting care more efficiently? And these are the questions that shape my project. And these are also the studies that I'll be sharing with you today. So, this study adopts a three-phase mixed method design. Phase one aims to understand LLM applications and perspectives. So we began with a scoping review to map existing evidence on how LLMs are being used in healthcare, followed by a multi-site cross-sectional survey to explore clinicians' views, perceived benefits and challenges. Phase two focuses on examining and understanding current practices. These includes in-depth interviews with nurses to capture their experience and insights, alongside a time motion observational study in the ICU to objectively examine, how nurses allocate their time, particularly for documentation and communication tasks. Phase three will then move on to more of a co-designing and innovation development, where we will bring together stakeholder focus groups and to interpret the findings and collaborative design an AI tool informed by insights from the earlier phases. So today's presentation will focus primarily on phase one and phase two. So we first conducted a scoping review to examine how LLMs are being used in clinical documentation. And we know documentation is essential, but it is also burdensome and a major contributor to burnout. LLMs offer potential solutions by generating summaries, structuring data, improving clarity, but there are also real concerns about accuracy, bias, privacy, and regulation. We've reviewed a total of 41 studies published between 2009 and 2025. Most of them came from the US and focus on tasks like generating clinical notes, discharge summaries, and encounter documentation. Reported benefits include greater efficiency, improved readability, and in some cases, up to 40% time savings. So, but at the same time, challenges were clear, such as things like inaccuracy, hallucinations, weaker performance in complex cases, and mixed clinician perceptions. While some found the outputs helpful, others worried about reliability, liability, and loss of clinical nuance. Ethical issues like data privacy, security, and algorithmic biases were also prominent. So overall, LLM holds real promise for improving efficiency and standardization, but their safe use depends on safeguards, co-design with clinicians, and building trust. They must support and not replace clinical reasoning and patient-centered care. So, as part of our scoping review, we looked at which large language models are currently being tested for clinical documentation and how they differed. So, on the left are the proprietary models like ChatGPT, Claude, Google Gemini. These are developed by large tech companies and are designed for conversation, text generation, and summarizing information. On the right, you would see the list of open source models like Bird, Llama, and others. These are more community driven and can be customized for healthcare tasks like discharge summaries, nursing documentation, or multilingual clinical notes. So you'll notice terms like encoder, decoder, encoder, decoder. These describe the model's role. So encoders are like good readers. They process and understand text, often for classification. Decoders, on the other hand, are good writers. Yeah, so they generate text such as summaries or draft notes. So encoder decoders are like readers and writers combined, like a hybrid. They read the input and produce a structured output, for example, turning a clinical conversation into a concise summary. So to put it simply, encoders read, decoders write, and then the hybrids do a bit of both, and yeah. So the main takeaway from our review is that while proprietary models are powerful and easy to use out of the box, but oftentimes open source models offer more flexibility for tailoring to specific clinical documentation tasks. This slide shows some of the main ways researchers have been evaluating LLMs in medical record keeping. So first is content accuracy and completeness. Here, the focus is on whether the information generated is factually correct, whether anything important is omitted or added, and whether the notes align with physician documentation or recognized nursing terminologies. And researchers also look at the technical measures like recall, precision, and fidelity scores. Second would be linguistic quality and readability. This goes beyond accuracy and to ask questions like, is the text clear, coherent, and grammatically correct? Is it easy to read for both the clinician and the patient? Studies also assess comprehension, tone, and even empathy in how the notes are being written. Third would be the summarization quality. Since many of these models are being used to summarize long clinical encounters, evaluation includes whether the information is well organized and logically sequenced. So standard metrics like Rouge, Blue, and BERT score are used, and sometimes researchers test different prompting methods to see which produces the best results. So overall, the evaluation is multidimensional. It's not just about whether the model gets the facts right anymore, but also whether the notes are readable, usable, and clinically meaningful. There are three additional ways LLMs are being evaluated in clinical documentation, one of which is clinician assessment. So often studies look at how efficient and time-saving the models are and how satisfied or accepting clinicians are of AI-generated notes. So some would measure whether LLMs could help reduce burnout and whether their summaries match or fall short of expert-written notes. Importantly, researchers also evaluate the potential for patient harm if something was missed or misrepresented. So fifth, we have the human versus LLM performance. This includes comparing how long it takes to produce notes manually versus using an AI, and whether the quality meets accepted documentation standards like the PDQI 9. And reviewers also examine hallucinations, instances where the AI makes things up, and how clinician reviewers rate the outputs compared to human notes. Finally, formatting and structure. It's not enough for the content to be accurate. Documentation also needs to follow, professional conventions. So models are evaluated on whether the headings are correctly applied, whether information is like grouped logically, and whether notes adhere to templates or structured formats. So together with earlier matrix mentioned, these give us a fuller picture of how LLMs are being rigorously judged, not just on technical accuracy, but also on the usability, safety, and the alignment with real-world practice. So far, we've looked at how researchers around the world are evaluating LLMs in clinical documentation. But one important question remains, what do nurses themselves think about these tools, right? So to explore this, as part of my fellowship, I carried out a study across Penn Medicine and the Children's Hospital of Philadelphia, focusing specifically on nurses' perceptions of chat GPT in healthcare. So the reason why I use the term chat GPT instead of large language model, because at that time, at that point of the study, LLM is not really a household term yet. People don't really know. If I were to ask a nurse, ask a nurse what they think about LLMs, they would probably, know nothing about LLM. But when we decide to use a more accessible term like chat GPT, something that at that point in time was getting more and more famous. It was something that was accessible and something that they could understand. That was the reason why we decided to drop the term LLM and replace it with the term ChatGPT. So this is part of the first phase of the work. It was a multi-site studies across a multi-site survey across 6 hospitals. So 5 in Penn Medicine Health System and 1 being the Children's Hospital of Philadelphia. And we had a total of about 681 participants. Most were female, as you can see, with an average age of about 39 years and around 15 years of nursing experience. Education levels were high, generally high. 63% held a bachelor degree, and 32% have a master's degree. In terms of work setting, 44% came from inpatient wards, 19% from outpatient, and 13% from ICU or high dependency units. Importantly, this was also a very digitally literate workforce, with 69% reporting that they were very familiar with computers, and another 30%, somewhat familiar. A key point to note is that 75% of the respondents in our survey had already used ChatGPT at the point of study, and about a third of them, specifically 34% of them, had used it more than 10 times. Yeah. So, with this experience and well educated, digitally engaged nursing workforce in mind, we then explored their perceptions of ChatGPT in their healthcare, focusing on both opportunities and challenges. So, here we asked nurses about what they see ChatGPT as useful in healthcare. So the strongest area of support was in research. So almost two-thirds, close to 65%, felt ChatGPT could help in tasks like drafting manuscripts. Similarly, more than half, about 54%, thought it could assist with appraising medical literature. When it came to patient-facing roles, opinions were split, as you can see. So about half the respondents felt it could provide support for families and patients, while the other half did not. But when asked about providing medical decisions, there was near consensus. Almost 90% of the nurses said ChatGPT should not be used for decision making in clinical care. Right. So overall, nurses recognized value in ChatGPT for research and literature review, showed ambivalence about patient support, but drew a very, very firm line, at autonomous clinical decision making. So we also explored nurses' perceptions of ChatGPT in relation to patient outcomes, trust, and comfort in use in practice. So on the left, you can see, when asked whether ChatGPT could improve patient outcomes, just over a third, 36% said yes. The majority, 53% were unsure, and just about 11% said no. So there was this like cautious optimism, but also significant uncertainty. In the middle, we see levels of trust in AI for producing medical decisions. Only about 1% said that they trusted it a lot, while 25% a moderate amount. But almost three quarters, expressed little or no trust. 45% said a little trust, 29% rated not at all. So finally, on the right here, we asked about comfort with using ChatGPT in practice. About half, 47% said they would be somewhat comfortable, while 16% would be very comfortable. But more than a third, 37%, said that they would not feel comfortable at all. So overall, nurses see some potential for improving outcomes, but there remains, a low level of trust in AI-driven decision making and a sizable portion of discomfort when it comes to integrating ChatGPT into daily practice. So you go deeper in and look at the barriers, nurses identified to using AI in healthcare. So the biggest concern was credibility. So nearly three quarters felt AI lacks credibility in healthcare, and legal and ethical risk were also major issues, with about 69% highlighting medical legal implications of using AI for patient care. 65% worried that AI would recommend wrong or harmful medical decisions. Almost half, said that they simply just don't know which AI models are safe to use in healthcare. And 42% worries about patient confidentiality. So you can see that there are also other barriers that included like perceptions about AI chatbots not being well developed, resistance from some healthcare professions, and also being unfamiliar with using AI chatbots. Interestingly, a fewer nurses, about 31%, are worried that AI might take over human roles, with only 18% saying that AI tools are not available in their work setting. So overall, the barriers are less about access, it's more about the safety, the legal liability, responsibility, and credibility. So these are definitely the issues that need to be addressed if an AI tool is to gain wider adoption in clinical practice. So in phase two, we shifted from perceptions of AI to examining current nursing documentation practices through qualitative interviews with 13 nurses at the Hospital of Pennsylvania. Hospital of University of Pennsylvania, HUP in short. So several challenges emerged. Yeah. So first was the time-consuming nature of documentation. Nurses describe frustration that documentation often takes time away from patient care. As one participant said, I think that, where a lot of our documentation is gone, more focus on the chart than the patient, right? And second, regulatory requirements were seen as low value tasks. For example, one nurse questioned why they had to write the same education notes every day, even when the patient's care plan hadn't changed. third was the considerable variation in documentation practices and standards, even within the same unit. Yeah. So I love this. One nurse described it as the wild, wild west out there. She has seen everything. If I don't remember wrongly, this nurse has about 20 years of work experience in nursing, and she told me that she has seen everything from no documentation to her type of documentation. Finally, nurses highlighted the problem of retrospective documentation and workflow adaptations. Some admitted documenting after the fact or back timing notes just to keep up with the demands. So the second theme that emerged was focused on their perceptions of AI and potential implementation, in with regards to nursing documentation. So we found a sense of guarded optimism. Yeah, so nurses could see potential benefits, but they were also highly aware of the risk and their own accountability. So one nurse actually noted that if I save something incorrectly and the patient's case ever goes to court, I feel a deep responsibility, for anything I save, right? And the second sub-theme was about ethical and systemic concerns. So nurses are understandably worried about privacy, data protection, and additional learning curve required to adopt a new AI system. And finally, they spoke about AI tool feature preferences. They imagined AI being most useful if it could, for instance, listen to patient assessments and auto-populate flow sheets while still allowing nurses to verify and edit. So overall, this theme shows that while nurses are not rejecting AI per se, they are very clear it must be designed to support their practice, protect patients, and preserve professional accountability. The third and final theme focused on organizational readiness and culture. So first, participants describe a cautious approach to innovation. So at institutions like in Penn, there's a strong emphasis on research and evidence-based practice, which creates both rigor and also a level of conservatism when adopting new tools. As one nurse puts it, we must do everything evidence-based. Second was the importance of nursing leadership as a liaison and advocate. Leaders were seen as critical in explaining and demonstrating and ensuring that the staff understood changes happening at the organizational level. This highlights the central role of leadership in bridging between frontline staff and the institutional decision making. Finally, nurses emphasized the importance of facilitating change through staff engagement. Yeah, so the way new technologies are introduced matters. If framed as being supportive and helpful, staff are more likely to buy in. If seen as an additional burden, resistance is expected. And as one participant reflected, it if it feels like another thing people just expect of us, I think there would be resistance. So overall, this final theme really shows that successful implementation of AI in documentation will depend not only on the technology, but also on organizational culture, leadership advocacy, and genuine staff engagement. So building on these findings, our next step is a time motion observational study in the ICU. The purpose is twofold. So first was to observe and analyze documentation behaviors of ICU nurses in real time. And second, to identify gaps in documentation practices, including, the hidden or invisible aspects of nursing work that often go unrecognized. We have four specific goals. So first, to quantify the time ICU nurses spend on documentation tasks, to categorize the types of documentation activities undertaken, examine how well documented information in the EHR actually aligns, with real nursing activities, and finally, to identify the workflow inefficiencies and highlight potential areas for improvement. So this phase will really give us a more granular practice-based understanding of documentation, which then can inform the design of the tool, and solution that are truly responsive to nurses' needs. So this slide outlines the design of our time motion study. We are now conducting the study at the Hospital of University of Pennsylvania in one of the heart and vascular ICU. Our target population are registered nurses who have at least 1 year of work experience within that current setting, focusing specifically on day shift schedule because of manpower constraints, on the research team side. So for sampling, we plan to collect up to 100 hours of observation in total, and this will spread across about 25 sessions, each lasting 4 hours, for example, like 7 to 11 a.m., and so on and so forth, so that we can have a robust observation throughout the whole 12-hour shift. This structured approach allows us to capture, the detailed picture of the nurses' documentation practices across different times of the day while keeping the observations manageable and representative. So this is the hospital, how it looks like. This is a video of the unit. You can see it's a really big, long, large corridors, and then every room on the side is an individual patient's room. So all these windows here are all patient rooms. So every patient room has a window. So it's really quite beautiful. Yeah, this is the room, how the room looks like. Yeah, so they have a computer inside where they can document. They also have a computer right outside where they can document as well. In addition to that, they also carry a hospital mobile phone where there is also the Epic EHR system downloaded in it as an app. So they could also do their simple documentation on their mobile phones. So to carry out this study, we use the time cat. So it's a digital time capture tool that is web-based. It's a web-based software. It allows us to observe and record nurses' work in real time with a structured timeline view. So we are tracking 4 specific dimensions. So they are documentation activity, what kind of documentation task is being done. Tools, whether nurses are using a computer, a mobile device, or any other medium. Nursing activity that goes beyond documentation, such as direct or indirect patient care. Location, we are also interested on whether the activity is occurring at the bedside, at the hallway, or where is the nurse situated when the activity is happening. So this approach gives us both a granular and also flexibility, helping us to capture not just how much time is spent on documentation, but also where, how, and in what context it takes place. So by mapping these patterns, we'll be able to better identify workflow inefficiencies, hidden burdens, and some opportunities where we can introduce AI innovations to make a meaningful change. Okay, so this is a snapshot. So we are still recruiting nurses and still collecting data, but this is a snapshot based on 5 nurses at the Heart and Vascular ICU across 34 hours, about 34 hours of practice. And we saw, I was really surprised, when we saw only 12% of the time was spent on documentation, while remaining 88% was devoted to every other nursing activities like direct care, monitoring, and coordination of care. So when documentation happened, it was overwhelmingly computer-based. So 86% of that 12% was done on computers and 9% on paper, and around 6% was on the work issued mobile phones. So it's important to note that, this is still ongoing data collection. So these are early observations, but the findings already highlight that while documentation is a relatively small part of practice time in this ICU context, but it is highly concentrated on computers. And that is also an important consideration, when we think about how tools like LLMs could be integrated into nurses' workflow. Very interesting, right? Yeah. It's something that still boggles my mind, and I'm trying to figure out why is it just 12% and they are still verbalizing a lot of burnt out. So across all parts of this study, there is a consistent theme that emerged, LLMs clearly have potential to improve documentation, making it more efficient, more standardized, and easier to read. Nurses also saw value in areas like supporting research and communication, and many expressed cautious optimism that AI could help reduce duplication and free up time for patient care. But at the same time, there were significant concerns, right? Like reliability, factual inaccuracies, hallucinations came up repeatedly alongside medical, legal risk, privacy, and ethical vulnerabilities. So for many nurses, these risks make them a bit hesitant about using LLMs for direct clinical decision making. Our qualitative interviews highlighted how documentation itself is experienced as a heavy burden with duplication, variability, and also coping strategies that sometimes compromise timeliness and accuracy. Yeah, and observational data kind of confirm this, showing that although documentation is a smaller share of overall time, it directly still competes with patient with bedside care. And so the message here is that AI in documentation should be viewed as an opportunity to relieve administrative burden, but only if it is implemented with strong safeguards, clinician oversight, and meaningful engagement with frontline nurses in design and rollout. So, as I studied how LLMs might support clinical documentation, I was initially really struck by their potential, to reduce burden and improve efficiency. But the more I observed and spoke with nurses, the more I was triggered to think deeply about the unintended consequences of this shift, right? So one concern is automation complacency. So if AI does the writing, clinicians may stop questioning or reflecting on its outputs. Another is the risk of errors or hallucinations that look polished but aren't always very reliable within all the fluff. And then there is also note bloating, right? Long standardized text that may obscure rather than clarify that clinical story. But the issue that stood out most to me is the risk of eroding critical thinking. Yeah, because documentation isn't just record keeping. At least that's for me and how I was trained as a nurse. It's part of how nurses and clinicians reason, right? So, writing forces us to reflect, to synthesize, and to make judgments. And if too much of that process is handed over to machines, we risk weakening the very skills that, underpin safe, thoughtful patient care. So while LLMs may help reduce burden, we need to be careful that they don't inadvertently, strip away the clinical reasoning that comes with writing. So after reflecting on these challenges, I began to think about what strategies could help us safeguard clinical reasoning while still benefiting from AI in documentation. So first, we need AI literacy. So one useful starting point for building AI literacy comes from the work of Kobesi and his colleagues in 2025, just published this year, who developed what they call the AI ABC framework. It's simple, but a structured way for clinicians to engage with AI. So A stands for AI basics, introducing the core concepts like what AI is, how it is developed, and how it actually functions in healthcare settings. B covers the benefits and challenges of AI, making it clear that AI can streamline workflows and support decision making, but also brings risks such as bias and over-reliance and hallucination. C focuses on core components and terminologies like, what is machine learning, natural language processing, algorithmic transparency, and what is data governance, and what does it look like, right? So second, we also need to train clinicians to verify, question, and refine AI outputs rather than just accepting what the system produces, right? They should be able to critically appraise and adapt it just like they would with any clinical information. A third would be simulation and case-based learning you can be used as powerful tools in preserving reasoning. So they let clinicians practice clinical reasoning with and alongside AI so that the technology supports rather than replace their judgment. And finally, co-designing is essential, and I'm an advocate for that. AI tools must be shaped with the input of frontline nurses. I find that very lacking. Yeah, I find that nurses are always an afterthought, and that shouldn't be the case, right? We should have the input of frontline nurses and clinicians to ensure that they are practical, usable, and aligned with real clinical context. Up to this point, I've shared some individual level strategies, but to truly safeguard clinical reasoning in the age of AI, we also need to think about the system level policies and practices that shape how these tools are introduced. So first, we should mandate AI evaluation frameworks that assess not only the accuracy, but also the cognitive load. In other words, does the technology actually support clinicians, or does it create new layers of complexity, to care? Second, AI literacy needs to be embedded in nursing curricula and even in licensure requirements, moving forward. If AI is going to be part of healthcare, then every clinician needs to have a foundational understanding of it to use it responsibly. Third, we have to monitor workload and clinician well-being. If AI shifts documentation tasks but inadvertently increases stress or reduces control, then we've completely missed the point of using it in the first place. Yeah. Finally, we need equity, transparency, and governance in the deployment of these innovations. These innovations and technology must be deployed in ways that are accountable, explainable, and fair, ensuring that both ensuring trust amongst clinician and also patients. So these policy and practice levers are really about making sure AI is not only effective but safe, ethical, and sustainable. So if you're interested, more details can be found in this publication recently published at the International Nursing Review. So in this paper, my co-authors and I, we explored both the promise and the risk of using AI in documentation, and we outlined some strategies for ensuring that critical reasoning remains central to practice. So I'd like to end with this quote, technology is adapted by adapted quote. Technology will never replace nurses, but nurses who embrace technology may replace those who don't. So for me, this captures the heart of the issue. Large language models and AI are not about taking away the role of nurses or diminishing our expertise. No. Instead, there are tools that, if used wisely, can help us spend less time on repetitive tasks and more time on what matters most, right? Caring for patients. But embracing technology doesn't mean blind adoption as well. It means engaging critically, safeguarding our like reasoning and shaping how these tools are designed and deployed. So if we nurses step into the role, then AI can be a partner in our practice, right? Supporting, not replacing us, supporting the human judgment and compassion that, defines nursing. So the challenge is not, whether AI will be used, but how we as nurses choose to lead its use. So I'll end with a picture of my family taken in Alaska during my fellowship year. Yeah, it's a reminder to me as well of why this work really matters. At the end of the day, beyond documentation and technology, what really matters is people, right? Yeah, people, relationships, and the time that we can give back to those we care about. Yeah, so thank you again for being part of this, conversation. If you like to stay in touch, stay connected, you can find me through LinkedIn, and I have a Substack like blog, where I blog my experience throughout the year in the US. So yeah, with that, thank you.
That's great, Brigitte. Thank you so much for a really interesting presentation. You covered loads of aspects of using LLMs in nursing. I was just wondering, how did you actually get started and get interested in AI research in the first place? Was it something you were always keen to understand?
Mm. So my area of research has always been looking at how I can support the nursing workforce. I don't claim to be an AI expert or LLM expert or even an informatician or whatever not. I see I am a nurse doing research for nurses. And yeah, so at the point of time where I had this opportunity to go to the US on a fellowship, it was also the time where LLMs and AI was really gaining a lot of traction in Singapore. But I noticed that not many nurses in Singapore, and I can safely say even in many countries, not many
Mm,
clinical nurses are involved in that conversation, honestly. Yeah. What really annoys me or saddens me the most is that when someone they will always build something for physicians first. And
yeah.
then, yeah, and like I mentioned in my talk, nurses are always the afterthought, right?
Mm,
They think that whatever that they design for the physician would also work for the nurse. But our jobs, our role in the healthcare is very different. And so it just can't be done like that. And so I decided that I'm going to plunge into this. I'm going to join the conversation. I'm going to learn more, explore more, speak to more people so that I have like a better sense of how I can move things forward for nurses and also bring along, like-minded people like me to continue on this work. Yeah.
super. That's great. Yeah. So, do you have any advice for nurses maybe who want to get involved in AI research? What would be the best things for them to do?
Yeah. So I think the first things first is not being afraid of AI innovations, not being afraid of using Chat GPT, because sometimes I feel like I'm not sure about the UK, but in Singapore, sometimes when I speak, or even in the US, when I speak with some of the nurses, they are very cute. They'll be very embarrassed, to tell me that they use Chat GPT to draft emails. I'll be like, what's wrong? If it's making your life easier,
Mm,
just use it, but of course, use it thoughtfully, right? You have to
mm.
check, you have to ask the right questions, check and check again. Yeah. So I feel like there is still that embarrassment of like delegating some task, like low value tasks to Chat GPT. So I think my very first word of advice to nurses, who are interested is to first explore tools that are readily available online.
Mm,
Yeah. Next, of course, when there's any new innovation with regards to AI within your health system, go for those talks. Meet people, meet like-minded people. Like something that is how I would advise myself as well, When I went to the US, not knowing anyone, I just went for events, talks that, are people that are like-minded, try to meet, connect, and learn from them. So I think that's one of the ways that they can start, yeah.
that's great advice. Yeah, I agree. And my last question is a little bit more difficult, but I guess AI is going to continue to advance. And yeah, what kind of trends do you think nurses should keep an eye out from that might come into healthcare who relate to AI?
With regards to AI, definitely things like documentation. Yeah, so that is something that is moving really quickly in the US and also in Singapore.
Mm,
But more and more often, we are seeing that because the design is not specific to nurse specifically catered for nurses in the first place, they are realizing that there is a lot of barriers to adoption. For instance, nurses are saying that so now there is this whole thing about ambient technology, right? Where
Mm.
you speak out your assessment, like your patient assessment, and then all that. Now they realize that they are speaking out like artificially for the tool rather than for themselves or for the patient. So they feel like I mentioned, when we want to deploy anything, we also have to assess the cognitive load on the person, right? Like, are we adding another layer of complexity to care? Now, not only I have to assess my patient, I have to speak it out, to my patient. Do we do that? And are we training a new generation of nurses that would speak out their patient assessment, like auscultating the lungs now, lungs are clear, and then
Yeah.
so yeah, so that definitely, like, in terms of clinical documentation, some a trend. In terms of I think Q&A, like addressing patients' queries, has been something that Singapore has adopted a lot as well. Another trend that is up and coming and also being deployed in Singapore now, and is the use of robots to facilitate care, like fetching things, preventing falls, yeah, keeping an eye of the patient, and it's like, oh, this patient has fall risk, then the robot will go to where the patient is and be a physical barrier for the patient. So these are up and coming trends that I see for nursing. Yeah.
Yeah, great, great. Thank you so much, and a really wonderful presentation. And looking forward to seeing more from you in the future.